Apologize, we seem to have some secretary to secretary breakdowns on getting LCs corrected. So as people present their bills today, please make sure that we have the correct LCs on it. So we'll start this out. Let's see. Okay, who? Here a minute. Somebody asked me to go. Okay. All right. On one of these bills, somebody had a working physician that wanted to testify and needed to okay, right there. Which bill is it? 909. Okay. Well then, Representative Silcox, if you would like to present House Bill 909, we will start the meeting off with that one and let our doctor get back to work seeing patients. She's been kept out because of our delays, and is it in here? Is it in here? Don't tell me we don't have it. Huh? Yeah, we got it.
Thank you, Madam Chair.
Okay, read the LC number so we can make sure we're working off of it.
It's LC 337307.
Got the right one.
Thank you so much. I come to you today to present House Bill 909. This bill has been brought to the committee by the Department of Public Health. And I want to welcome our guest, Katie Kopp, from the department, who's going to tell us more about the bill after I just give an introduction. But basically this bill is similar to the cardiac bill that we did last year. The idea is to really allow hospitals to have levels for perinatal facilities. And basically my understanding is in the past we've had designation for neonatal, but we have not had designations for hospitals for perinatal. The benefit, of course, of having the perinatal distinction, it would include caring for the mother prenatal as well as the baby, and this would be a more comprehensive designation, and I think it would help with our very low statistics in terms of infant mortality, among other measures that we are always in the 40s in. So I'm going to let Katie talk a little bit more about this.
Thank you. Thank you to the members of the committee and to the chair, especially for letting us go first. Just to expand on what Representative Silcox said, there are 36 other states that have a very similar program to this. And basically what's happening right now in Georgia is that hospitals self-designate their level of care. So this would give some oversight and consistent standards for hospitals in Georgia that we haven't had before. Hospitals are basically using national guidelines to sort of self-designate their level of care, and this would give the department the ability to set up guidelines that work for Georgia. It would be for both maternal and for neonatal levels of care, and we would let hospitals choose to apply. It's voluntary, so they don't have to, but they would be able to choose to apply for either maternal or for neonatal or for both, and we wouldn't require that they be at the same level of designation for both of those. We also have put in there a sort of a start date of 2019, so hospitals would be able to apply in the following year, which would give us 1 full year to work with all of the partners, the hospital community and the provider community, to set up exactly what those designations would look like through rulemaking. And just to emphasize too, this bill doesn't require that hospitals transfer any patients or prohibit them from taking care of certain patients. It's simply a voluntary designation. So I'm happy to answer any questions.
Okay. We have questions from the committee. No questions from the committee. Do we have people signed up to speak? If you'll come forward and identify yourself.
You want me to stand here?
Yes, ma'am.
I'm hobbling with a hamstring injury. My apologies. I'm Jane Ellis. Good afternoon, Madam Chair, members of the committee. My name is Jane Ellis, and I'm here to speak on behalf of House Bill 909, on behalf of myself as well as the Georgia OBGYN Society. I'm an associate professor of gynecology and obstetrics at the Emory University School of Medicine, fellowship trained in maternal fetal medicine. Simply put, I take care of pregnant women who have an increased risk of maternal or fetal complications throughout their pregnancy. I also serve as the medical director of the Emory Regional Perinatal Center at the Grady Health System, one of the 6 regional centers, perinatal centers in Georgia. I'm a native Georgian, grew up on St. Simons, went to Georgia Tech for an engineering degree undergraduate, decided I did not want to design helicopter cockpits for Bell Labs for the rest of my career, so I went back to Georgia Tech for a PhD. Once I finished my PhD, I had developed an interest in obstetrics, so I went to Emory Medical School, and then I did my residency in OBGYN and fellowship in maternal fetal medicine there. So all told, I have been learning at, teaching at, working at Emory and Grady for about 22 years now. My colleagues who serve as medical directors in the other regional perinatal centers also believe that this legislation is needed in Georgia. As Representative Silcox mentioned, hospitals in Georgia currently self-designate their levels of care. This legislation would ensure that hospitals providing care for mothers and their infants are able to do so based on the patient's complexity of needs. This legislation would also allow the Georgia Department of Public Health to establish oversight for the hospitals in the program to ensure that once they've completed the designation process, they then recertify at specific intervals. This is not a one and done type of legislation, which is an important aspect for this program. As a maternal fetal medicine physician practicing in a large regional center, I can tell you that the goal of a designation program like the one contemplated in House Bill 909 is for pregnant women and their fetuses and infants who are at high risk for complications, and to make sure that they receive adequate care in a facility that is geared toward their particular needs. And hopefully in that process we would be able to reduce morbidity and mortality. I have taken care of patients who, had they not been at the facility where they were, would probably have had poor outcomes for their pregnancy. I have also taken care of patients who unfortunately did not receive care in an appropriate facility or were transferred too late in their pregnancy and went on to have a bad outcome. Just as a brief example, I was the MFM on call a couple of years ago for Grady and Emory Midtown. I received a call from a small hospital who had a pregnant patient there. She was about 36 weeks pregnant, seemed to be developing preeclampsia. So they called for some information about blood pressure management. I asked them to just transfer the patient to us at Grady. They felt that they would be comfortable managing her preeclampsia as well as her 36-week pregnancy. As I talked to these physicians several times over the course of the evening, it was clear that the patient was developing a very malignant form of preeclampsia called HELP syndrome. They delivered her via C-section, and unfortunately she went into DIC following her C-section, which is a coagulopathic disorder that's life-threatening. The hospital did not have an ICU facility, nor did it have an adequate blood bank for the products that this particular patient needs. So much to their credit, they were able to stabilize her and get her to Grady, to our ICU. She was in fulminant liver failure, and we were working with Emory main campus to stabilize this woman and get her transferred to Emory for evaluation for a possible liver transplant. Unfortunately, she went into cardiac arrest and we were not able to resuscitate her. Now, I can't say for sure that had she been at Grady from the get-go, would the outcome have been any different, but I like to think maybe it would have made a difference for her. This woman had had her first baby. She was 18 years old.
Thank you. Doctor, can you sort of shorten it? We are running
I'm done.
behind.
I was going to thank you for the opportunity to speak, and I'll be happy to answer any questions.
Okay, I didn't warn you before, but also
okay.
people are going to testify, please.
That's fine.
Let's keep it short. Thank you. Are there any questions for the doctor? If not, thank you very much for the
Thank you.
work you
I
do and
appreciate the
taking care of
opportunity.
these very seriously ill patients. Thank you. Is anybody else that's going to speak on this bill? Right where? We've got it? Okay, seeing no one else that wants to speak on the bill. All right, committee, what's your pleasure?
Motion to pass.
Okay, I have a motion to pass and second. Is there any further discussion? All right, seeing no red lights, go on. Everybody in favor of the passage of House Bill 755, no, wait a minute, 909, House Bill 909, say aye. Anyone opposed, say no. All right, the ayes have it. Thank you very much, Representative. Okay. Okay, Representative Laricchia, are you here? Somebody's supposed to go get him?
Supposed to let him know. You
Oh, let me see if I can find another one that's quick. Okay. Pardon? He's coming? Pardon? Okay, Representative Bennett, go ahead. All right, House Resolution 1016. Move fast. Don't fall. You got your flat shoes on? Okay. Okay, give us the LC number. We're, like I say, after last meeting, make sure we have the right LC numbers on everything.
Yes, ma'am. LC 1170072.
We've got it. That should be in your folders.
House Resolution
If this is
1016.
quick, Laricchio, just come and sit. Can you sit here for a minute? Okay, go ahead.
Madam Chair and members of the committee, thank you for allowing me to present to you House Resolution 1016. Diabetes is a serious disease that affects both genders and cross-cultural, socio-demographic, and geographical boundaries in Georgia. Approximately 9.9% or 734,800 Georgia adults have been diagnosed with diabetes, and 25% of them approximately are over the age of 65. Likewise, the total cost of diabetes in Georgia is estimated to be about $7.6 billion. This includes $5.5 billion of direct medical cost and $2.2 billion of indirect medical costs of lost productivity due to diabetes. Diabetes has been the 7th leading cause of death in Georgia. The burden of diabetes impacts working age adults, while diabetes in older adults is linked to higher mortality, reduced functional status, and increased risk of institutionalization. To aid in this growing predicament, Georgia has 96 diabetes self-management, education, and support programs, and 28 recognized national diabetes prevention lifestyle change programs to cover at this time. While we recognize the good that these and other like programs are doing to make greater strides in improving the health of all Georgians, it is paramount that Georgia continues to develop strategic partnerships and engage stakeholders at all levels. Encouraging Georgia to promote health in all policies approach can improve the physical and social well-being of Georgia citizens. Therefore, House Resolution 1016 encourages the Department of Public Health and the Department of Community Health to work together around the state health benefit plan and Medicaid to expand coverage of accredited diabetes self-management, education, and support programs. Members of the committee, I ask for your favorable approval of this important resolution that promotes the health and safety of Georgians.
Okay, thank you. Any questions for the representative?
Move to pass.
Okay, got a motion to pass and second. Is there anybody from, that signed up to speak on this? No. Okay, as I've always said, if we don't find something to control diabetes and Alzheimer's, it's going to break the country. So I appreciate you bringing this resolution. Okay, we have a motion to pass. No further discussion from anybody? Okay, everybody in favor of the passage of House Resolution 1016, say aye. Aye. Anyone opposed? No.
Thank
Okay,
you.
the ayes have it. Thank you very much. Representative Laricchio, I understand you have a special guest for us. And that guest with his family. And as you heard, we're a little backed up.
That's right.
And you have a resolution. That would be Resolution 988.
Right.
Okay. It's in your folders, everybody. And can you tell us the LC number to make sure we're working off the LC?
Well, Madam Chair, that particular resolution was already passed. What we were going to do is to make the committee aware of the particular disease that Jerem has.
Okay, all right.
And so I appreciate you giving us some time, because I had them up this morning for an invite resolution. And to try to get right into it, the rare disease that Jerem has, and this is Jerem, he's 9 years old, Jerem Waldron. This is his mom and dad, Chris and Amber Waldron. Jerem has congenital adrenal hyperplasia. He actually has the salt-wasting version of CAH, which is the most rare and most life-threatening, the most serious of the CAH. That is from an enzyme disorder that's a 21 hydroxylase deficiency, and what his body will not produce, androgens or cortisol. And so he's a salt waster. Instead of doing that with the potassium and sodium, his body won't retain that. But they also have some other guests with them that wanted to be here, and I just wanted to call their names. They're sitting behind us. Ashley has her daughter Emma, who's 14, the son Coy, who's 11, and Evie is at home. She's 6, and she's an adopted little girl from China. They are all salt wasters and congenital adrenal hyperplasia, all in that one family.
Have them stand up so we can welcome you to the Capitol. There we go. And wait a minute. And you've adopted?
We did.
I did. Thank you very much
Thank you.
for being an adoptive parent. We do appreciate that.
Andrew and Catherine Montgomery are with us. Their little boy Liam is 5 years old. He is the salt wasting CAH, and there's only about 1 in 20,000. So sort of put that into perspective. In our districts, you may only have 2, if any. Maybe have no CAH salt wasters. And so
Okay, wait. Liam, thank you for coming to the Capitol today. Thank you. Okay.
I'm just going to tell you briefly how I got involved, and I wanted Amber just to share her story about Jerem and what has happened.
Okay, now I know in the South you
Yeah.
talk a lot.
That's right. That's right.
So can we condense this and let's let this mama talk
Well,
to us?
Chris and I are lifelong friends, all the way back to teenage years, and I began to read about it on Facebook, about Jerem's condition, and follow it. And they called me one afternoon and said, "Hey, would you come out to the house and let us talk to you?" And I'm not sure how many hours we sat there, but I really fell in love with the story of congenital adrenal hyperplasia, in particular salt wasters. And the limited access that they have to health care because of being in rural Georgia. It's 2.5 hours to the nearest pediatric endocrinologist. And so I'm going to let Amber share the story of Jerem and how this all happened to them, and then just close with our overall goal of awareness of these rare diseases.
Thank you.
Thank you for coming.
Jerem was born in August, and he was a big baby. He was 9 pounds 4 ounces, and he was a big, healthy-looking, round-headed baby. He was born, and he did show signs of jaundice, and so afterwards we kept him in the hospital for a few days, and Chris and I would travel back, and I would feed the baby, and that lasted about 3 days, and he got to come home with us. And when we got home, he was like my last baby that was 9 pounds 4 ounces. He was a lazy eater, and he slept a lot like newborns do. And I started to notice that he was losing weight, and babies will do that, but he was losing weight, and he started to feel like my baby that was my first child, which was 8 pounds 1 ounce. And we happened to get a call, and he was 10 days old, and we got a call from the hospital that said that the test that they had run,
Profile on the baby.
Yes, the profile, the blood profile that they had done on the baby, that they came back abnormal. And, here we have a 10-day-old, and it was really confusing because when you don't have medical terminology and you're hearing someone call you and say, the levels are really extreme, you need to get them to the hospital. We live in Douglas, which is about 3.5 hours from here. And they said that you have the Eggleston Children's Hospital is waiting for you. The emergency room is waiting for you. And so, I trying to wrap my head around it. I asked them, well, how long do we have? I'm thinking, do I need to pack a bag? And she says, you have less than 24 hours for your child to live. And so we don't know what hour that 24 hours started. So we got in the car and with a very, very sick and fragile baby. And we got to the hospital in 2 hours. And they run some tests and they said, we're not sure if he has it. We're going to see if he does. And once they ran the test and they confirmed that he did, they gave him his emergency medication, Solu-Cortef. And his body started to come alive. His color came back. And his eyes, that had been gaunt, they filled in. And he started to look like a little bit more healthy baby. We were taught how to treat his condition. He takes different medications. He takes hydrocortisone to replace his cortisol that his body does not make. And that's something that's lifelong. He won't grow out of it. And he takes another medication to help him use his sodium, because otherwise he would waste it. And he is a very active child now. He plays sports. He's an honor roll straight A student. He is just as active as other siblings, but we do have to watch him. There is an emergency medication, Solu-Cortef. It's an injection that we have to be careful when he gets sick, if he gets a virus, if he has a fever, if he has stress on his body, if he breaks a bone, if he were to break a finger or a toe, or anything else for that matter, he has to have that Solu-Cortef injection to save his life.
Well, I appreciate you coming. You have a great representative, and Representative LaRicchia, and he's very concerned about patients and trying to help patients in South Georgia get the need, especially when they have a rare disease or need unusual medications, and I appreciate that. It's sort of a passion of mine, too. I taught pediatric nursing. So Jerem and Liam, it's pretty scary to come to the Capitol and, sit down there with all of us. But you know what? If you didn't come, a picture's worth 1,000 words, and you're a picture, and you let us see the face of this rare illness. And it makes the legislators up here more aware of how important the work we do in making sure that you get the medicine. So to the families that came, thank you very much for this. Now we have a face on this illness. LaRicchia, you want to close it up?
Just thank you so much, Madam Chair, for allowing us a few minutes to tell their story. And I wish that as this progresses, they could sit down individually with you and hear the dad's side, because there's nothing like hearing a dad talk about praying over their child and blessing them before they go on a 3-hour trip, thinking that the baby might not live until it makes it to Atlanta, which is a whole nother rural Georgia conversation that we'll have. But thank y'all so much for letting us present.
Representative LaRicchia, you don't have to say that to me. I made that trip from Valdosta with a very sick husband.
That's right.
One time, and I know what it's like. And I flew. Probably didn't make it in quite 2 hours, but it was close.
Thank y'all very
I was
much.
flying low. So thank you for coming. Thank you for bringing this to us. And I wish you, Jared, the best, and all the children that are here, and glad that you have such caring parents. Thank you.
Thank you.
Okay. Representative Dempsey, is she here? There we are. Okay, let's go with House Bill 647. Can you give us, Representative Dempsey, please give us the LC number.
It is LC 337344S.
Got it. It's the right one in your folder. Go.
Thank you, Madam Chairman. So this bill is to deal with the challenge of obesity that we face in the state of Georgia. I know many of you already have heard me speak to the pilot that addressed bariatric surgery, which thanks to y'all, it'll be on the floor tomorrow. I'm excited about that. But this is another issue, another way to look at this challenge. There are more than 3.1 million people living with obesity in Georgia, and more than half of those people will develop diabetes, heart disease, hypertension, arthritis, obesity-related cancer, sleep apnea, gallbladder disease, and other health issues related to obesity. Health care for this population has been shown to cost significantly more than health care for the normal weight population. And this population tends to miss significantly more days of work. In the summer of 2017, a study was conducted with DCH that showed surprising results that that about 70% of the state health benefit plan population is either overweight or obese. That's 70% of our current and retired employees and teachers. A BMI of 25 to 30 is considered overweight, and greater than 30 is considered obese. By taking the sum of the direct and indirect costs, it's estimated that the total differential cost related to obesity in the state employee population in 2017 is predicted to be $1.4 billion and rising to $1.9 billion by 2026. Thus, the total cumulative differential cost related to obesity over this period is estimated to be $16.7 billion. The State Health Benefit Plan does not currently cover FDA-approved obesity drugs for the treatment of obesity. By adding coverage for FDA-approved obesity drugs, the Department of Community Health will be able to provide another option for the treatment of weight loss. Other states, some of our neighbors, Florida and Oklahoma, are also running a pilot program. Kentucky, North Carolina, Tennessee, and Virginia each offer full coverage for their employees of these medications. The drugs have been approved and safe to use by the FDA in patients with a BMI greater than 30 and the patients with a BMI greater than 27 who also have other co-occurring conditions. Clinical trials have shown the effectiveness, particularly in those patients with co-occurring conditions such as diabetes that we just heard from just a little while ago, with the average patient losing more than 5% of their body weight. The National Institutes for Health have recognized that even a small percentage of weight loss, 5 to 10% of current weight, can help to lower the risk of developing these other debilitating diseases. So this bill will look at a 2-year pilot program to provide coverage for the treatment and management of obesity and related conditions under a state health insurance plan for 1,000 employees. 2 years, 1,000 employees. The department shall be authorized to enter into an agreement with a post-secondary institution in this state for the pilot program management, data collection, patient engagement, and other activities related to the pilot. The program will provide coverage of all federal FDA-approved drugs that treat obesity. So that is what it does.
Okay, questions from the committee? Representative Reinders.
Thank you, Madam Chair, and thank you, Chairwoman Dempsey, for this. And this is a problem that we've recognized for some time. My only concern is, and I just want to make sure, the program doesn't work if you don't follow the program, obviously.
That's right.
That makes sense on anything, a plan of action. But I would hate to sign up for something not necessarily knowing the full details of any particular program and then be asked, you must do this, 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 and this. And I guess what I'm asking is, if someone agrees not to do this, 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 and this, since that would be mandated by the particular program in the pilot, is there any way that they can be kicked off of the state health benefit plan?
No.
Okay.
They might be asked to be removed from the pilot.
I get that.
But not.
I get that. You got
They
to.
would not lose.
If you're serious, you're serious. But I would hate
Right.
for any of that information
Right.
to be used as a reason to deny current services.
That has not even been part of the conversation.
Okay,
at all,
but
just yet.
but it's a logical question, because people are going to ask about their privacy, especially in healthcare nowadays. I don't want, for quality purposes, this call may be monitored, but there's always people that are a little nervous about that phrase. So I just want to make sure I ask the question for the record.
Absolutely. So if you look on page 2 of the bill, line beginning with line 33, it speaks to the criteria to be included in the program. You know, which this includes wellness counseling, that
Right.
you will agree to co-pays. I mean, there's a lot of upfront agreeing.
And I
to
was
go
looking
through.
at lines 48 that said shall be subject to the health insurance carrier's plan of benefits and policy provisions. And I would hate for somehow to be asked to, I'm following a provision that I didn't know what was being asked of me originally, or found it more difficult to adhere to. It was a little bit tougher or whatever, and then for whatever reason, be somehow denied the opportunity to continue.
Well, as I understand it, so you would fill the prescriptions on a regular basis. If you were not meeting the thresholds in counseling opportunities through the wellness program, there would be an opportunity there to step away.
Right, and
So
and
that's-
and again, if you continue on that line on 49, participants shall be responsible for all applicable co-payments, and I get that. State shouldn't have to pay for it. But if it was this much and I thought it's going to be this much, then I may choose to opt out. I just want to make sure that they're not harmed in any other way because they felt like the program might not have been for them after the fact. And you're telling me that's not the case.
Well,
So
I appreciate your interest in bringing that forward. It's a very good question. It has not even really been a part of the discussion that you would lose your benefits, so.
okay, thank you so much. And thank you for the bill.
Okay, who's this person? Oh, Representative Hilton.
Thank you, Katie. Just a question on and I guess it stems from line 43 here. Walk me through, what does the obesity treatment program look like? Does it involve certain medicines? Walk me through that a little bit.
It would probably be a very individualized plan for each person, I think. You know, depending on how high your BMI was. So goal setting, working through the wellness program as well.
So I guess the patient and their physician, they come up with a plan together.
They will.
And then,
They will. And you know, like if you have this high of a BMI, and some people are not very big actually and have a high BMI. It's a challenging issue, but when 70% of our employees are dealing with this, therefore we're going to be paying for much more expensive procedures and drugs and medication. Ongoing diabetes medication can become very expensive in the plan. So this is also a way to look at, and after 2 years in the analysis going through it, to see if this truly helps, if it is a cost savings overall to the program as well as a life-saving benefit to many of our employees.
you said the number is 70%. That's not how many, do we know the number of how many people, state employees that are suffer
I
obese?
have someone with me if he could speak
Be
a
fine.
little bit to that. Leonard Bennett is here and has done some data collection on it.
Hi, good afternoon,
Good
Madam Chair and committee. Thanks for the time to speak. Yeah, we work with the state very closely using their own demographics, and it was actually 75% of the state population is either overweight or obese in the state health benefit plan. 31% were overweight and 44% were obese. And that is a population out of 638,000 patients in the state plan.
I'm sorry, how many patients?
It was 638,564 members in the state
Members.
health benefit plan.
And 44% are obese?
44% are obese and 31% are overweight, headed toward obesity. So 75% of the population from the demographics that were given to us from the state health benefit plan are either overweight or obese.
And there's certain drugs that they could take.
Yeah, there are currently 4 approved drugs for weight management on the market. But, you know, with any type of weight management program, you would also use wellness and diet and nutritional counseling.
Okay, thank you.
Yes.
Okay. Are there other questions for Representative Dempsey or Mr. Bennett? Okay, we've got one. Okay, well, use hers. It's Representative Petrie. You're on.
Yeah, I've got it. I think I'm on. Yeah, the first thing I would say is, as a large employer, we need to be careful about who we're hiring. It sounds like an HR issue for the state as well.
That might be discrimination.
Well,
And since I've probably
stand by my
fallen,
comment. At any rate, Representative Dempsey.
Representative, I can't believe you said that when you look across our legislature.
There you go.
I know, right? I mean, thank you. Woo! rude.
Any further comments?
I think I'm gonna send you to your room.
Yeah, good. Thank you. Representative Dempsey, you alluded to the fact that we have, this is patterned after other states that have done this as well. So what of and you're going to do a study here, you're going to have 2 years, and we're going to see the results. So what have the studies proven to be in other states? Because the assumption would be they would be likewise here, hopefully. Sounds like we may have a worse problem here than most states. I suspect, and I hope so. But at any rate, so what has the outcome been in other locations where this has been tested?
Well, I can speak to it first, and then if you have any more information. But Florida and Oklahoma are in a pilot right now. The other states that I mentioned actually just adopted this back as part of their protocol in their state health benefit plan as one of the drugs that are available.
Since they found it effective.
So if there's
The issue is that there's not a lot of real world data yet because the products have only been on the market for around 2 years. Before that, there were no products on the market other than one which was withdrawn from the market called Meridia. After the fen-phen crisis we had in the 90s, pretty much the obesity market, there were no products available to treat other than phentermine, which nobody uses, which is a generic product. So actually, currently there are 4 products on the market. 2 are controlled substances, 2 are not. 1 is an injectable. So there is a large interest from the research arm in the pharmaceutical industry around obesity because we know obesity leads to all these other comorbid conditions that we're currently paying for and seeing the healthcare costs rise.
I would say, too, that much like the bariatric measure, we're looking at 2 ways, multiple ways, actually, if you consider the number of drugs or the number of procedures, the 3 procedures for bariatric surgery that can be done. We're looking at some ways to reduce the challenges that are in our state health benefit plan. Private insurance allows for this. It's not in ours because of the cost. So in order to look at it and study it and see if there are good results or if it's not something we should look at, this is the beginning point.
Representative, thank you for bringing that point up because I think since we have the pilot project to continue it for surgeries going forth, I think this would be good that we can compare and see whether treatment with medication is just as effective or more effective than expensive operations, or if it doesn't work as well, if people do better with the operations. I think most people, if it was just as effective, would prefer to take a medication rather than have some of the bariatric surgery. But we really don't know that until we do studies. And
I believe it's my understanding too, Madam Chairman, that these particular prescriptions will work pretty quickly.
Yeah.
You'll see that they are working, or you'll be removed from the pilot in essence. If your body is not responding as it should, it's not going to respond better months out than it does at the beginning.
I think one of them is if they don't respond by 16 weeks or
Right.
something like that, it's basically not going to.
The label reads at 12 weeks for 3 of the products. You need to lose 5% of your body weight within 12 weeks, or the medication does not work for you. You should be stopped. The other one is 16 weeks, or you should stop the medication if you're not responding and losing 5% of your body weight.
So, okay. We got another question? Representative Pruitt?
Madam Chair, I just wanted to be available for a due pass when the
Okay,
time is right.
thank you, Representative Schofield.
Just a quick point of clarification. What's the difference between this medication and a regular diet pill?
They're new.
What would you consider a regular diet?
Well, a diet pill. I mean, there are just things on the market. There's Slim Fast and
Oh,
other
so
diet.
over the counter, right. So those are not prescription medications. Those are actually like bulk enhancers. So like Slim Fast just adds bulk to your stool so you feel fuller. These actually work. There's 2 ways. One of the mechanisms is energy expenditure, so it makes you release or use more energy. The other one is decreasing energy intake.
Gotcha.
So depending on which one works best for you.
Okay, thank you. I was familiar with that.
Okay. Representative Silcox.
Thank you, Madam Chair. I was just curious, what are the side effects of these drugs?
It depends on which product you're on. 2 of the products are combinations. Some of them do have increased heart rate. Some of them, like one of the drugs is a combination of naloxone and Wellbutrin, which is an antidepressant. The other one's a combination of topiramate, which is used for seizure, and phentermine, which is a stimulant. Leucocerin, which is Contrave, actually inhibits some of your appetite suppression. And then the other one is Saxenda, which is a injectable, and it is a GLP-1 that is used at a lower dose for type 2 diabetes, at a higher dose as weight management, because it totally suppresses appetite.
Thank you.
Thanks.
Okay. Any further questions from the committee? I don't see any. Mr. Bennett, I think you were the only person signed up to speak on it.
Thank you.
So therefore, what's the pleasure of the committee? All right. Oh, right. Sorry. I've got a measure do pass. Do I hear a second? Second. We have do pass in a second. Everyone, any other further discussion? Okay. Everyone in favor of the passage say aye. Aye. Anyone opposed? No. Ayes have it. Thank you very much.
Thank you for your time.
Thank you.
Dempsey. Okay. HB 513, Representative Dickerson. I think you can, just don't get comfortable. Stand up and let's make it quick. I know, I like that. There we go, there we go. Make sure, if you'll read the, if you will give us the LC number.
We're reading from LC 297496.
We've got the right one. Go.
Okay, thank you, Madam Chairman. I would like to present House Bill 513. This bill is a very simple bill. The only thing that it would do is have some uniformity and signage for newborn babies. This goes along with the Georgia Safe Haven Act, which we amended in 2017. Under the new Safe Haven Act, a law, a newborn can be left at a safe haven location for up to 30 days after birth, versus the 7 days in the original bill, where the mother no longer needs to have identification to leave her baby. What I'm asking in this bill is that we have some uniformity in the signage in different facilities, which there is none at this time. I did talk with the Georgia Department of Family and Children's Services, and they made a recommendation on line 11 that the Department of Community Health shall develop standards for a sign. And I would like to incorporate that language into the bill.
Shall develop,
Yes,
what is it?
standards,
Okay, shall develop standards?
yes,
For?
for a sign that shall be posted.
Okay. All right, we'll get to that as an amendment in a minute. Is that it?
Yes, ma'am.
Okay, Representative Reinders.
Chair, and thank you for your interest in this subject matter. I have a question at the end of line 11 and at the beginning of line 12. What is your definition of any medical facility, and is that term in code anywhere?
Yes, it is.
Okay. I withdraw the question. Thank you so much.
Okay.
Okay, thank you. Betsy, can you, Representative Reinders, I had to ask to make sure.
Yeah, it's any licensed general or specialized hospital, institutional infirmary, health center operated by a county board of health, or a birthing center. It does not mean a physician's or dentist's private office.
DNC or anything like that. All right, good enough.
All right,
Thank you.
okay. Other questions for the representative? I mean, I think the problem is that with all our bills, we don't have a way to get information out about what we pass always, especially something like this, telling the public where they can drop a baby safely. If you'll remember from the bill we passed last year, we said they could drop it up to the time the baby was 30 days, and that the mother did not have to identify herself, because before she did, and we felt like that was one of the reasons that they were leaving them on doorsteps and in unsafe places. So, because they were being asked to identify themselves when they didn't want to. So we changed that, but we just feel like, and the representative felt like, we need to get that information out with signs so people will know the safe places to leave children. Because we had a couple of deaths. Thank you. There's
I ask
no-
for your favorable consideration in this bill.
Okay, is there anybody who wants to speak on it? We have nobody that wants to speak, so what is the pleasure of the committee? We have a move to pass, and like the secretary, who says? Representative Bennett, or,
Wanted to, at the point of time, move to pass.
oh, well, okay. We have a measure do pass and a second. Any further discussion? No further discussion. Everyone in favor of the passage of House Bill 513? Oh, wait, okay, let me hold that off. We got a thing. Okay, let's do the amendment first. At the, okay, line 11, after develop, the amendment would be standard 4. Do I have a motion on the amendment? Have a motion, second? Okay, any discussion? Everybody in favor of the amendment, say aye. Aye. Anyone opposed? No, okay. So the amendment passes so that it would read, the Department of Community Health shall develop, well, it should be standards for standards for a sign that shall. Okay, now back to that. Everybody in favor of the passage of House Bill 513 as amended, say aye. Aye. Anyone opposed? No. Got the ayes have it. Thank you, Representative.
Thank you, Madam Chairman.
Okay. Representative Knight, are you here yet? There we go. Okay, Representative Knight. House Bill 1194. House Resolution 1194.
Thank you, Madam Chair.
You give us the LC number.
Let me see. I apologize, Madam Chair. I'm running from about 3 different committees today.
Yeah, it's that way. We're having a lot of confusion over because of that.
It happens this time of year, doesn't it?
Yes, sir. Okay.
Let me see if I can look that up on the real quick. Just it should be the what's the LC? It should
LC
be
33. Yeah,
I
but
know
I just
no,
want to make sure.
Madam Chair, I know of no changes to
Okay,
the House
fine.
resolution, so
Okay.
that should be it. Madam Chair and members of this committee, I know that it's no secret that this state, along with this nation, keeps dealing with the ever-rising cost of health care. Quite frankly, we also see the never-ending problem of trying to figure out exactly what health insurance is going to do and not do for you as far as your benefits. And specifically, this resolution is trying to put together a study committee that is going to look at not a new problem, but a pretty recent problem in the state of Georgia of health insurance going back and retroactively trying to decide if they're going to pay for an ER visit. I think that's one of the most egregious things that I've ever heard. Madam Chair, I don't know if I have enough of the copies to hand out, but I have a letter.
Kim, Jessica, can you just give them to my aides?
Yeah, I have a letter that
Kim? Jessica? Y'all can.
over the interim, this problem was discussed, and myself and Senator John Albers met with some folks from some physicians along with Blue Cross and Blue Shield, trying to understand why this policy was being put in place, but not only why it was being put in place, to figure out why physicians were not called in to, if there was a problem, your physicians should be your first line of trying to determine and get people to if there's criteria that the health insurance companies are worried about, let those doctors know so that they can look for different ways perhaps to get patients to maybe a less urgent health care issue. So what we did is we asked Blue Cross and Blue Shield, what is the criteria by which you are making these retroactive decisions? In fact, we had the insurance commissioner or the deputy commissioner wrote a letter to Blue Cross and Blue Shield, as you see in front of you, asking, what was the criteria? And again, Blue Cross and Blue Shield asserts that these billing codes and the information is proprietary information. It's like everything else we see in the health insurance industry today, there's no transparency. Zero. None. And who ends up suffering are, quite frankly, the folks who think they've got insurance, and then they come in and they find out that they either the insurance company, the insurance coverage that they thought they had is inadequate, and that they're stuck with a bill, especially in the cases of an emergency room visit. Madam Chair, some members of this committee may remember even my personal history with my wife, pulmonary embolisms, you know, in the history that we've had. So anytime that something happens that we know, we've talked to physicians that may be a sign of, we've been told to go to the emergency room, okay? That's the life and death issue. How many of us in here are probably in the room and probably around the state, you know, heart issues? Well, is it indigestion or is it truly a heart attack? So we're in essence, this policy that we're looking at here that's being implemented is in essence gonna ask the insured to play doctor and make some kind of a judgment as to where the emergency room care is really needed, because they're going to be sitting here worried about, are they going to end up with thousands or tens of thousands of dollars in bills? So again, that's the purpose of this study committee, Madam Chair, and I would hope that the members will join in with me in supporting this measure, and maybe we can start looking into what's going on behind closed doors and why these decisions are being made that is so adverse to Georgia's patients or the folks who think they have insurance. Let's do something for them.
You on the insurance committee?
No, ma'am, I'm not on the insurance committee.
What a shame. I have a little bill over there that is trying to prevent patients from getting big bills when they're taken to the emergency room and then they're stabilized and their insurance carrier is out of network. And
ma'am, Madam Chair, you know, you and I have spoke on this before, members of this committee have. You know, transparency is the best cure for what ails, I think, the whole healthcare situation that we've got. We've let insurance come between our physicians and our patients, our healthcare providers and our patients. And I'm with you on a lot of these issues. You know
yeah,
that,
I know that.
Madam Chair.
Well, and the hospitals are fun. All they have to do is make one phone call, and you know, they seem to think they don't have time to do that. But we're working through it. Okay, Representative Pruitt.
Thank you, Madam Chair. Just quickly, Chairman Knight, I can remember distinctly 12 years ago, before I ever came to my first session, that this was an issue, and one of them was down the same line. But when you go to the emergency room, that's what's really hurting our rural hospitals, because the insurance companies, they don't determine the code as an emergency room required visit. So the hospital, obviously the emergency room is very expensive to go to, and the insurance companies just pay the emergency room fees to the hospital at a very, very much lower rate. And so the question is the hospital have to determine whether it's an emergency or not, or they have to send them away because they know it's not an emergency, therefore they can't take them knowing that they're only going to get part of the money back from the insurance company, so, or even Medicaid and Medicare, really. But so will this study committee dive into that?
I think we're going to dive into it. I
Okay.
think we're going to dive
Thank
into all of this. And certainly we all know that there are folks who are using the emergency room for purposes that they should not be using the emergency room. You've got a emergency room physician that's sitting here on your committee. I'm sure he could tell stories about issues where somebody could have gotten health care at a much lower and less, you know, costly measure, but chose to use the emergency room. But that's not what this issue is about. This issue is about codes, and somebody may walk in and may have a serious heart issue, cardiac issue, or a blood clot issue, or think they have, and then all of a sudden, you know, go through testing, which a physician prudently should, and follows all the protocols, and then all of a sudden, retroactively, the insurance company then sends a bill and says, "Oh, we're not paying for this. You're responsible for it."
Representative
quarterbacking after the game's over. Yeah.
Thank you, Madam Chair, and Chairman Knight, I appreciate you bringing this issue, and it's been around forever. And, you know, I love the legislative process on the various ways of skinning a cat. So I'm certainly not opposed to adding one more whereas. on this particular piece of this resolution here, where they say something to the effect of, whereas they must immediately on their webpage have an icon entitled "What You Don't Get" or decoding, and must immediately disclose all codes not covered by Blue Cross and Blue Shield. Just giving you something to think about when you move forward.
Well,
because we are the legislature, and if people don't act in good faith and in transparent ways, we can skin that cat another way. So just
Well, I appreciate it, Chairman Reinders. I tell you what, I hope this is a successful resolution, and we got a study committee, because I'd welcome your participation on it. And especially, guys, think about rural Georgia and the initiatives that we're doing right now. This is important all over Georgia.
Right. So if you're teeing this up and you need to hit away later, just let us know.
Thank you, Chairman Reinders.
Thank you.
Okay. That's the last question from the committee. We have two people that want to speak. Tim Kibler.
Thank you, Madam Chair. Tim Kibler with the Georgia Alliance of Community Hospitals. We're an 85 hospital association of Georgia's not-for-profit hospitals. Very much support this legislation. We feel it's right and appropriate that the legislature take a serious, long, hard look at this. We've got a lot of Georgians that are going to be, as Chairman Knight said, essentially required to self-diagnose before they appear at the emergency room or risk significant financial harm. We don't feel like that's appropriate, and we appreciate the support of the author and the authors of the legislation, and commend it to you and ask you to move it forward.
Thank you. Derek Norton.
Thank you, Madam Chair, members of the committee. I'm Derek Norton, representing the Medical Association of Georgia. We are supportive of this effort. We think this policy is a terrible policy that puts Georgians in a bad spot to self-diagnose. The examples are coming in from not only Georgia, but from other states. And I know the chairman mentioned, having chest pain that turns out to be indigestion and retrospectively denied. There was a case recently where a woman went in with side pain thinking she was having an appendix problem, ended up getting in a wheelchair, wheeled back, and then it turned out to be cysts. And so they retrospectively reviewed that claim and said that wasn't an emergency, and she was stuck with a $12,000 bill. So Georgians shouldn't be put in a position where they're worried about going to the emergency room because their claim might not get paid. So we support this effort, and thank you for the chairman for bringing it forward.
Thank you. I certainly think it's a good bill. We want our hospitals to get paid and not have Blue Cross Blue Shield or other people making medical diagnoses. On the other hand, we would like them to also ensure that patients don't get stuck with bills when their carrier's out of network and that kind of problem. Okay, that's all the questions. Well, what does the committee like to do?
Madam Chair, is there anybody here from Blue Cross Blue Shield that may want to? There's always two sides to every story, so we don't know if they want to talk to us.
Well, I don't know. The way they treated Grady until they finally resolved that, I'm not sure I want them talking. We can't make it without Grady. Okay, we've got a do pass motion and second. Any further discussion from the committee? Hearing none, everyone in favor of the passage of House Resolution 1194, say aye. Anyone opposed? No. Okay, the ayes have it. And moving on. All right, let's go. Representative Park, Cannon, H. Bill 755. 755. Give us the LC number.
The LC number is 337189. Thank you. Thank you, Madam Chair. Thank you, committee members. I bring to you House Bill 755, co-chaired with Vice Chair Lee Hawkins. It is regarding PrEP, which is pre-exposure prophylaxis. This bill deals with our state's opioid crisis. It establishes a public-private partnership for a pilot PrEP drug assistance program to cover the testing costs associated with PrEP. This pilot program will initially focus in 4 counties that are being identified by the CDC. It's on the map that you are being handed now of being on the brink of an HIV outbreak due to the high use of opioids. This is what happened in Indiana in 2015. Governor Pence called a state of public health emergency, and this would just put us in line to deal with the issue on the front end. I have spoken with the Fulton County Director of Health, who would be helping to implement the program, Department of Public Health, the Infectious Disease Section, Highland Rivers Community Service Boards, Gilead, the Speaker's Office, because his district is in this, the 4 reps whose districts are included, and also the Health Appropriations Chairman, Mr. Parrish. If there are any questions or you'd like me to walk you through the bill, I can do that, but you do see the fiscal note here. This is about $380,000 to stop us from having an HIV outbreak. Thank you.
Okay, that physical note does cover 3 years, correct?
It covers all 3 years at 50% retention rate, or we could go at a lesser note for 25% retention rate, and it would be a little less than 300,000, around 262.
Okay. I think the one thing that you did, and I would like to make an amendment, Betsy, you can write it up. Okay, that this would go into effect upon appropriations.
Correct.
Okay, so we need to add that at the end when we get to that point. Okay, Representative Reinders.
Thank you, and thank you so much for this legislation. I know there's a problem with needles and HIV, right?
Correct.
And so I was just glad that this committee passed 10-6 last week to make sure that we have safe needles throughout the state of Georgia. So thank you for working in a spirit of cooperation on both issues.
That's what it is. Thank you.
Okay, and that bill will be on the floor tomorrow for a floor vote on the needle exchange program. It's Representative Price's bill. Okay, just so you'll know that it'll be there tomorrow.
Thank you.
Questions for the representative? No questions? Okay. Oh, sorry, okay.
Representative, so the counties are Fulton, Fannin, Harrelson, Murray, and Towns.
Correct.
So you've got a good diverse group of counties, rural, urban.
Correct.
Very good. Thank you.
Okay. Representative Stevenson.
No question. I just wanted to thank you. I've spent a lot of time on the HIV planning, and what you've put together would help all those counties and eventually help our entire state. So I thank you.
You're welcome.
Okay. I will remind the committee that last year we had over 14,000 new cases of Hep C, which can be a devastating disease and is very expensive to treat. Who we got from anybody from the? We have nobody else from the to speak on it. Pardon? Okay. Let me get a movement at the appropriate time. Go. I may do pass. Okay, I've got a motion to pass. I've got it in a second. Okay, I've got a motion in a second. Let's go with an amendment. Okay, Betsy. Hey, everybody, listen up. Let's see what Betsy says.
Okay, on page 2, we're going to add a new section 2 between line 39 and 40. And if y'all have a copy of Representative Dempsey's bill, we're going to use the same language in that. It's on page 3 of her bill. So we're going to use that same section 2, which says, this act shall become effective only upon the effective date of the specific appropriation of funds for purposes of this act, as expressed in the line item making specific reference to such act in the General Appropriations Act enacted by the General Assembly. A little wordy, but that's the idea. We'll have to make 2 other kind of conforming changes on page 1 to the title. We'll add after the clause to provide for related matters, add to provide for contingent effectiveness.
Okay.
And then the last thing is back on page 2 on line 34. That date, the December 31st, 2021, won't work, just depending on when it's funded. So we'll change that to no later than 42 months after the effective date of this code section, the department shall submit.
Okay, and also on line 40, wouldn't that become section 3?
Yes.
Okay. Does anybody want Betsy to go over that again? Okay, we have the amendment. I've got a do pass on the amendment. Do I have a second? Oh, wait a minute. Who? Representative Pruitt, do you have discussion on that?
No.
No? Okay. Okay, on the amendment, I have a motion, do pass in a second. Everybody in favor say aye. Aye. Anyone opposed? No. Okay, the ayes have it on the minute. We're back to the House Bill 755 as amended. And we have a motion, do pass, and a second. So everybody in favor of House Bill 755 as amended, say aye. Aye. Everyone opposed? No. Okay, the ayes have it. Thank you, Representative Campbell.
Thank you.
Okay, we have one more resolution that just got passed out for you. Okay, this is a substitute to House 447. It's LC 337343 South. Representative Rakestraw.
Thank you, Madam Chair and members of the committee. I have House Resolution 447 that we started on last year. Speaker Pro Tem Jan Jones gave me this and asked me to carry it. And this is a resolution that declares pornography a public health crisis. And I hope they pass these out too. There was this from the Georgia Baptist Mission Board. They passed something similar, and they were not able to testify because they had other committee meetings. But they wanted me to let y'all know that they have 1.6 million members and 3,500 churches that have passed a similar resolution declaring pornography a public health crisis. And this from the Concerned Women of America. So because we're the sex trafficking capital of the world, we thought this would be a good bill to help prevent sex trafficking, because there are a lot of teens that are getting exposed to pornography on the internet, and they're becoming addicted at younger and younger ages because of access to pornography on the internet. And this is affecting young teens, both male and female, and it's impacting their relationships and their ability to well, there's on the back of this sheet, I'll just read some of the stats. They said a minor is more likely to be exposed to pornography if the minor possesses risk factors, including a high risk of depression or delinquency, if the minor is a victim of harassment. The exposure of minors to pornography detrimentally affects the health and safety of state residents, increasing the risk for illegal sexual behavior and sexual violence. Of the minor males exposed to pornography, 42% viewed pornography that depicted violence against women. The exposure to and use of pornography by minors is a risk factor for adolescent sexual offenses and sexually aggressive behavior by minors, particularly among males. And people that are exposed to pornography are more likely to engage in aggressive and antisocial behavior. Men who view pornography are significantly less likely to intervene as a bystander and report increased behavioral intent to commit rape. And the outrage from pornographers to increase these efforts has been loud, and legislatures are coming to terms with the reality in which we're living, and taking on porn problems as a serious societal development allows them to increase education for young people of the damages they might experience by going down this path. The addictive qualities are especially problematic. It impacts the same area of the brain as the drugs. They said that cocaine impacts in the brain. And right now, it says 6 states have already passed this, and it's pending in Florida and Maryland. I was told there were already 9 states, so I'm not sure which is correct. But this is a movement. But with us being the sex trafficking capital of the world, I thought it would make sense for us to try to do something preventative to bring this crisis, awareness to this crisis and resources to education to prevent sex trafficking.
Questions? As I talked with you earlier, I have a couple of amendments that I want to make that didn't get in. On line 1, it is not a public health crisis. It has not been deemed by the Georgia Public Health Department that this is a public health crisis. And so where we have public health crisis, I would want that changed to public health concern, since it has not been designated by our public health as a crisis. And on line 13, and I'll make this amendment motion later. At the end of the thing, it says, and this leads to, and I would say, and this may lead to low self-esteem. I don't believe.
Which line is that?
13.
Okay.
And I'll make that amendment, those amendments at the correct time. Okay. Representative Petrie.
Oh, Petrie?
Yeah.
Thank you, Madam Chair. It just struck me as you were, and of course we just saw this, but I saw, I don't know how many of my colleagues here saw this as well, the mass murderer from Florida that they finally executed. I forget his name, very famous. Bundy, Ted Bundy. I saw an interview they did with him before they sentenced him to death. And he basically he acknowledged his deviancy and laid it at the foot of pornography. It was interesting to me at the time when I saw that interview. He said it all began there. And as I read through this, it reminded me of that. He spoke about how he began with it and it got worse and worse and worse and more violent. And I absolutely believe, being a father of a daughter, I believe that so much of this stuff is so horrible in terms of how it treats women. And so at any rate, I just wanted to tell you that it reminded me of that Ted Bundy interview, and I thank you for bringing it.
Thank you.
Okay.
And I don't know if we can make a change to call on the public health department to, look into this and, report back some statistics of, how this is impacting, because I don't know that they're really seeing it because of, the lack of mental health resources that we have in our state. I don't know if they're actually seeing a lot of this type of mental health breakdowns, but or connecting those dots between this and sex trafficking. So if we're going to wait for them to declare it a crisis, I'm not sure that's going to happen in my lifetime, but unless things change. But
well, I think this is a step, and you can certainly come back and you can talk to the health department and see what they have to say about that. If there's anybody from the health department who would know about it, they can certainly speak up. Okay, I think that's something for you to follow. Okay, this group. Okay, we have some people that want to speak on this. Courtney Dow. Okay, and you need to be succinct.
Yes, ma'am. Hi, everybody. Hi, my name is Courtney Dow. I was born and raised in Atlanta, Georgia. So that's my representative right there. Hi. I went to Parkview High School, and I graduated in 2000, and then I went into Auburn University. War Eagle? Yeah, no.
You're in the wrong
go
state.
Dogs and Eagles and Owls. What else do we have here in Georgia? So I love Atlanta, which is why I moved back here. I actually, after my undergrad, I moved to Bangkok, Thailand. I worked with the International Labor Organization there, which is a department of the United Nations, and then I started working with women in prostitution in Bangkok. And so I worked with women who were from, and individuals, boys, girls, men, women, from Thailand, Cambodia, Vietnam, Burma, Laos, India, Uzbekistan, Ukraine, Turkey, Uganda, Kenya. I spent 2 years in Bangkok, and then while I was there, this was in 2004, I started getting emails from concerned friends who were saying, hey, guess what? This is happening in Atlanta. This is happening in your own hometown. So I came back, went to grad school, and I've been in Atlanta for the past 10 years working with individuals in prostitution. I spend a lot of time in strip clubs and brothels and on the streets, and and in jails where we're working with victims of commercial sexual exploitation. Some of my team members are over there, those hooligans that have been making a lot of noise. That's them. Sorry about that. We are extroverts, so because that's what we do. So, and something that I've noticed in working, and last year alone, our outreach team ministered to 4,300 people working in the sex industry of Metro Atlanta. Our jail team ministered to 330 victims of commercial sexual exploitation that are being incarcerated right now. And we really, I'll just put this as a side note, we want to move toward restorative justice, not just incarceration. So that's a goal and a heart for us. So in these 13 years of working with women in prostitution, something that I've noticed is that we cannot separate or segregate trafficking, prostitution, stripping, pornography. They are inextricably connected. We like to separate them. It makes us feel better, but there's no way to separate them. Recently, I have been contacted by teachers and administrators at local private and public schools who have asked me to come and talk to their students because they are having sexting scandals that is devastating some of the young women that it's happening to. And so one of the things that I do when I go and talk to these students is I have them anonymously write on a card how old they were the first time they saw a pornographic image. And then we average it out for the whole group. And I've done this with hundreds of students from 8th grade up to 12th grade. And the average has been 11 years old in those groups that I've done it with. The youngest has been 2 years old. And the child who saw that was through a video game. I'm not sure if you're familiar with Grand Theft Auto, but in Grand Theft Auto, you can purchase a prostitute, have them perform a sex act or rape them, and then murder them. And when you do that, you get extra points. So we have very young children who are being taught that it is not only acceptable to treat women this way, but it's also celebrated. Now, until we start changing that dialogue with them, we're not going to end violence against women and children. So a couple hundred people were here at the Capitol today. You saw the purple scarves. Yeah, they're probably really annoying, getting in the way and all up in the elevators. And they wanted to let you know that trafficking is an important issue to them. And the only way that we're going to fully address trafficking is if we address all these other things that lead to trafficking. And it's a lot of issues. It's education, it's health, it's the welfare system, it's the foster care system, it's all these things, but pornography is a huge piece of it. And it goes a long way in addressing demand. So thank you so much for letting me speak. I want to introduce my friend Michael, who's going to share a little bit about her story. So thank you.
Hi, so as she said, my name is Michael. I am a survivor of sex trafficking. And this resolution is really important to me because pornography is more than just self-gratification. When I was underneath a malicious pimp during that time of my life, I had men coming to see me that I wasn't able to turn down. And a lot of these Johns wanted me to act out the things that they had seen in this pornography. Things that I feel like some of the trauma that I experienced I feel like my trauma would have been lighter or lessened had it not been for pornography. I think of pornography kind of as the marijuana of the sex slave industry. I think of it as the gateway drug. I also know an 11-year-old who has recently come out that she's addicted to porn. My niece is 2 years old, and she's able to unlock my sister's phone. She's able to click on YouTube videos and stuff like that. And as it is right now, it is far too easy for my 2-year-old niece to accidentally stumble upon something. Our children, 4, 5, 6 years old, if they hear a word, a 6-year-old hears the word sex, they can sound it out and spell it. They know how to get on a phone nowadays. They type that into Google and videos will pop up, porn will pop up. And it's way too accessible and way too easy. Pornography, I don't see how in any way it aids or benefits our society. I think that all it provides is a degradation of women and of men. And I just think it hurts us rather than helps us. And there's definitely an epidemic and a need for a resolution.
Michael, thank you for coming. I know it took a lot of courage. Thank you for breaking free, or whoever helped you. I agree with you about the internet. It's caused a lot of problems in many ways. I'm not so sure that the good outweighs the bad. But I guess we will see that as we go forward. As I think Google just made it easier for even younger children to get on the internet. I'm just glad that my dog can't do it. And I say that to lighten the load a bit because I know you've been through a lot, and I really appreciate you coming, and thank you very much. Here again, if you heard me say earlier to the little ones that had the salt problem, putting a face on this and somebody having the courage to come means a lot more, even though the advocates are important. It means a lot more to the legislators. So thank you very much. Thank you.
Thank you.
All right, we have no one else to speak. Can we, Tanya Diddy?
Yes, I'll be brief. My name is Tanya Diddy. I'm the State Director for Concerned Women for America, and we really appreciate the representative bringing this forward. We're just here in support of the resolution, and we ask that you support it. Thank you very much.
Thank you. Okay, let's get a motion. Move to pass. Got a second? All right, let me bring it with the amendment. Okay, the amendment would be on line 1, it would strike the word crisis after public health and put concern. On line 3, it would strike crisis and put concern. On line 13, at the end, it would say, and this may lead to low, so they would add may lead. And on line 30, it would strike crisis and put concern. Do I hear a motion? So moved. I have a motion and a second. Any discussion? Okay, everyone in favor of the amendment, say aye. Aye. Anyone opposed, say no. Okay, the ayes have it on the amendment. And back to the resolution as amended, the substitute to House Resolution 447 as amended. We have a motion of due pass and a second on it. Is there any further discussion? Okay, everybody in favor of the passage, say aye. Aye. Anyone opposed, no? Okay, the ayes have it. Okay, we have one more, and House Bill 747. This is a bill I did, and I'm going to let Marcus Down have his say. Can you all find it? 747. I also have a bill moving in insurance that has to do with STEP program. One of the things that we have, and patients across the states are having, who have very serious illnesses, are often made by insurance companies to change the drug that they're on that's working because it's not on the insurance's formulary. And then maybe they've changed their formulary. And when you have a serious illness like Crohn's disease, sometimes that is just enough to throw you back into a severe illness, need hospitalization, maybe further surgery. The STEP program, what it has is just sort of putting another pills process for patients to do it. There are drugs that are very specific, and this one was brought to me. It has to do with medications for people that are hemophilics. And, okay, Marcus, you can take it from there.
Thank you, Madam Chair, members of the committee. I know the time is really late, so we're going to do this as quickly as possible from our end. Essentially, House Bill 747 is a bill that would protect hemophilia patients' access to their product without delay. It will help ensure that they have opportunity to have a very positive health outcome. For anyone who's not familiar with the disease, most people think that you cut yourself and you can bleed uncontrollably. Hemophilia not only affects external cuts, but also internal. So if I were to walk up to Representative Stevens and bump my knee or my elbow on the corner of this dais, then I could have a bleeding pool on the inside, which could cause hospitalization. One of the other things that really concerns my group particularly about this preferred drug list or prescription drug list is the fact that hemophilia isn't like aspirin. So what works for me may not work for Representative Stevens. What works for Representative Stevens may not work for Representative Petrie. It is a very individualized, very rare disease. We want to thank Madam Chair for taking this issue up. This bill was on the agenda several weeks ago. The bill was pulled out of deference for the Department of Community Health We want to work with them. We believe that they are going to take some strides. We met with them on Friday. We want to show that we have confidence in their ability to help address this issue. I will go on record. There are 11 different manufacturers who are affected by this. I want to stress, and some of you may have heard, that this is about the product. This is not about the product. This is about the class of diseases. There are 41 states who have chosen to leave hemophilia as a rare disease. There are only 9 states who have actually put this on a preferred drug list. There are several states who have considered it but have backed away because of the rarity of hemophilia. So with that, I'd like to introduce Bill Spear. He's the Senior Director of State Affairs for PPTA. Thank you.
Okay.
Good afternoon, Madam Chair. May I proceed?
Okay. Pull the microphone up. There we go.
Is that good?
That's good.
Okay. Thank you, Madam Chair. The Plasma Protein Therapeutics Association appreciates the opportunity to testify in support of House Bill 747, which would ensure that Georgia Medicaid enrollees affected by hemophilia have access to their medically appropriate therapies. Plasma protein therapies are used to treat rare life-threatening diseases. Blood clotting factors are plasma protein therapies made by our member manufacturers that treat individuals with hemophilia. To give you an idea of how rare hemophilia is, it's estimated that only 700 people in Georgia have hemophilia. This bill would benefit Georgia Medicaid recipients by ensuring they have access to the therapy preferred by their provider. This is important because blood clotting factors are not interchangeable. There are no generics. There are no therapeutic equivalents for them. According to the medical experts with the National Hemophilia Foundation, choice of the medically appropriate blood clotting factor for an individual patient requires a complex medical decision-making process with the ultimate product being agreed upon by the patient and their respective healthcare provider. As the chair has talked about today, occasionally payers implement policies that are contrary to cost-effective quality care. An example of this is step therapy, where a patient must fail first on a preferred blood clotting factor selected by the prescriber. This is a delay that is selected by your Medicaid department, actually. This is a dangerous policy for individuals with hemophilia, since a single failure could result in an intracranial hemorrhage that is fatal. It is also cost-effective. It is also not cost-effective quality care, because in failing on a preferred therapy, a patient may have adverse events that are painful and costly to the payer. House Bill 747 would protect individuals with hemophilia from such strategies, and that's why PPTA supports this bill. I appreciate your time, and I'm happy to answer any questions.
Representative Sharper, you have a question for the presenter?
No, I just had a comment.
Okay. I don't see any questions. Oh, sorry about your mic.
No, quite all right. Thank you, sir. 700 people in Georgia, very rare. What is your estimate for the number? This relates to Medicaid recipients only.
Right.
What is your estimate for number of Medicaid recipients in Georgia that might be hemophiliacs?
Do you have that number? I thought you had that number.
Probably most of them.
Based on the meeting that we had on Friday with the Medicaid and the department, they say it's about 100 individuals.
About 100. And what is the range of cost with these medications? Are we talking about medications that are extremely expensive or not?
These medicines treat very few people. They take about a year to manufacture, depending on how they're produced. Some start from donated human plasma, some are recombinant analogs. They cost about $1 a unit. But an individual gets a certain number of units based on their weight. And so it's not unusual for someone with hemophilia that is on prophylactic care, and they infuse about twice a week, to have costs for therapy well over $100,000 in a given year.
Okay, so very expensive treatment. Thank you.
Sir.
Thank you.
Oh, okay. Representative Sharper, you want to make a comment?
Thank you, Chairman. But, I think I really appreciate you guys bringing this because we lost my wife about 19 years ago when she was having our youngest son, and that's when we found out she had von Willebrand's. So, this is very important, and actually she has to make sure she has refrigerated medicines all the time. I mean, even when she go to the dentist, she have to take it with her. She have to keep it refrigerated all the time. So this is, you know, the people that is going to help, I think, is going to be very, very beneficial. So I really appreciate and support this 100%.
Thank you, sir.
Thank you. Okay, the stance we're in on this is that after the meeting with the department, I'm not going to move the bill this year. In the STEP program, they ask us also to remove Peach Care and our Medicaid people from that in order to get it passed. There is a new commissioner at DCH. He's been there for about a year. He has a different attitude about, you know, working with people. They've instituted some new procedures. They assure me that they are going to listen to the patient's doctor as they go forth. So far, they showed how many people gotten the medication before they changed policy, and they had not denied people this medicine, and that it looks like the STEP program now, thanks to the insurance companies coming around and working with me, may pass, and that they would follow those, like, you know, first, don't do any harm. If they're on something and it's working, leave them alone. If they've changed, you know, if they've tried this medication before and you change your formula, don't make them try it again. That's our stance for this year. I'm going to watch them. I'm sure Marcus will help me do that. But I hope that will go forth, and if it doesn't pan out that way, we can always come back and go out and get them next year. Thank you.
Thank you, Madam Chair.
Thank you.
Thank you, members of the committee.
Thank you, Marcus. Right. Well, thank you, and I appreciate it. And if it makes the STEP therapy makes it to the floor, I'll need your help. Thank you very much.